Assalamu alaikum. Thank you so very much, Maruf family, for joining us this beautiful morning. Today's session is attributed to the critical threshold in maternal mortality, despite attention being paid to maternal health at regional and international platform. We still have very doomed picture at the moment. I begin my presentation with a verse from Holy Quran. Bismillah ar-Rahman ar-Rahim. Whoever saves one, it is as if he had saved mankind entirely. I would like to share with you a case of a 30 years young girl who was going through her 5th pregnancy, all previous 4 cesarean sections. This time, during her 5th pregnancy, she was diagnosed as a case of placenta accreta spectrum. This is a term used when placenta morbidly adherents and penetrates down into the myometrium. She had a good antenatal care and she had her cesarean section planned at a tertiary care hospital where she ended up in cesarean hysterectomy. She encountered massive obstetric hemorrhage. She went into DIC. She received almost 30 units of blood products, transferred to ICU on bench. Patient remained critical post-operatively. On 3rd post-op day, she was transferred to Maruf ICU, vented. At admission in Maruf, she was in severe metabolic acidosis. Her CRP was 357 and she died within 3 hours of transfer to ICU. Unfortunately, there was no autopsy, no registration of maternal death, and no documentation anywhere that a young girl has died during pregnancy event. In 2019, WHO, UNICEF, and other agencies, they produced a report on maternal mortality saying globally every day, 830 women die from preventable complications, 94% occurred in low resource setting. In 2020, the global maternal mortality ratio was 152 deaths per 100,000 live births, out of which 94% we are saying that they occur in low resource setting. Sustainable development goals were set, aimed to reduce global maternal mortality to less than 70 per 100,000 live births by 2030. Pakistan contributes substantially to regional and global maternal and perinatal mortality figures. But unfortunately, the exact magnitude of maternal death is still not precisely known. Although 2018 Pakistan Demographic and Health Survey revealed that it has dropped down to 178 per 100,000 live births. But PDHS has been funded by USAID and United Nations Population Fund, is based upon the household surveys, and throughout Pakistan there were only 530 clusters of population which were selected, and only 12,000 people had questionnaires who filled the questionnaires, and we developed this document about the Pakistani health survey. So most of the women who die are poor. They live in remote rural areas where death is accorded little significance. Worse still, it's in most developing countries, maternal mortality rate is highest, but it is rarely recorded. There is no system of entering or documentation of these maternal deaths. And unfortunately, when a mother dies, the causes of death are never known. We try to gather some information to have some basic insight about this problem based upon this small survey which we conducted in AJK rural areas of Rawalpindi, Chakwal district and suburbs of Islamabad. We identified 4 main themes attributing to maternal death in low resource setting. I will take these 4 themes one by one during my presentation. Risk of dying is greater for adolescent girl. When an adolescent girl becomes pregnant, she is a high risk pregnancy and she is more at risk of death, contributing to maternal deaths and maternal mortality. Repeated pregnancies or multiparity makes them more vulnerable to death. If a woman repeatedly becomes pregnant with no sufficient interval in between to gain her optimal health, then again she is at risk of death. Not least of all, unmet need for contraception. That is, unintended pregnancies do happen and they also put a mother at risk of dying. PDHS 2018 revealed that 48% of pregnancies were unintended. That means they were unplanned, or in other words, you can say they were unwanted. Therefore, according to PDHS 2018, 54% of those pregnancies, that means more than half of the pregnancies, they ended up in unsafe abortions, putting maternal life at risk again. And despite all these problems, rising rate of maternal death ratio, population explosion in Pakistan, people still believe that this is against their religion, social, and cultural norms, and nobody dares to talk about family planning or birth spacing publicly or on any social platform. Key findings of family planning in PDHS 2018 were this CPR, by the way, is purely gynecological and it means contraceptive prevalence rate. The contraceptive prevalence rate in 2018 survey was 33% and it was stagnant. In 2013 survey, again, it was 33%. I don't know, people don't want to share proper information or they just give what is the recall. Out of these 33%, modern contraception used in only 25%. The methods used were female sterilization 9%, condoms 9%, and rest of the methods also were used. The most common reason for stopping contraception. Why women end up contraception, this is the women's own desire to become pregnant. 44%, followed by method related health concerns. There are a lot of myths about family planning things, and women usually they end up taking these family planning precautions because of all these myths and negative propaganda by different medias. So coming to the obstetric factors, no antenatal care, infrequent care, or late booking during pregnancy were identified as a major killers in our survey, added with non-recognition of early warning signs. Early warning signs are ignored by the family and by the woman herself. And when she becomes critical, she has glymptic fit, she has bleeding, massive hemorrhage, or intrauterine death, then they bring her to the hospital. And still in the hospital, there is non-compliance and tendency to decline medical advice by the attendants or by that poor women. And this is true because I just share with you one case in which a woman after abortion, she was in sepsis and she was brought to the hospital at 4-gram hemoglobin. Once the attendants were asked to give blood because we needed urgent transfusion, they took the patient away and then they just left the hospital. At registration, we got her phone number, we continued calling them, and finally they blocked our number and stopped to respond. We never knew what happened with that poor girl who was in sepsis and who had 4-gram hemoglobin. This is how the families react to the maternal health and maternal emergencies in Pakistan. Additionally, maternal mental health mostly goes unidentified, further worsening the situation. In a survey published by us, we had 36% postpartum depression in our women. Study was conducted in the Islamabad and its suburbs. So mental illness is not that infrequent here. Key findings of PDHS 2018 on antenatal care and delivery. This was 51% women had at least 4 antenatal care visits. 89% women receiving antenatal care reported their blood pressure being checked. 69% of deliveries are by skilled birth attendants and 66% in a health facility. Urine and blood samples were taken from 7 in 10 women. So WHO analyzed this data, which was obtained from PDHS home surveys, and they came up with policy recommendation. They felt there is an urgent need for implementing comprehensive pregnancy care. Maternal and perinatal death surveillance response. This is a document, simple form, which has to be filled whenever you encountered any death and has to be submitted in the regional and country level. And we don't have that MPDSR except for PIMS. I think they do it regularly, but no other hospital. I'm not aware of any hospital who documents and registers these maternal deaths. And there is a need for adoption of quality of care standards. Quality of care, mother and neonatal care is very important. WHO has made these documents available on their website, like implementation of labor care guide, respectful maternity, and essentials of newborn care. All these documents are there. WHO frequently get hold of the people and do the workshops and try to train people, try to put everybody on board so that we can help in reducing maternal mortality in Pakistan. And last but not the least, effective women counseling and care for abortions. Empowering frontline healthcare workers with autonomy and resources to improve service delivery has resulted in transformational change worldwide. However, things are quite different in Pakistan. This was a very interesting paper, good on paper, the gaps between program theory and real world context in Pakistan Community Midwife Program. This was published in British Journal of Gynae in 2015. In 2006, Pakistan Community Midwifery Program was initiated. They recruited women for 18 months of midwifery training, and this was aimed to provide skilled birth services in their community. These were the women selected from their communities, and they were supposed to go back and serve in the community. However, when the follow-up was done, it was found out that only 1 to 3% of women reported using midwifery services, and thousands of women continued to die during childbirth. Social and cultural factors were found to be the main cause. People usually discourage women from entering the midwifery profession, and the basic excuse usually is they have to travel in the field, they have to work alone, or they have to travel with their staff boys who are unfamiliar when men, and that should not be allowed. So another factor was that there is a difference between traditional birth attendant and skilled midwife. Traditional birth attendants are there from generations, and they have managed their grandmothers, mothers, and the family members. So people trust more on traditional birth attendants, though the maternal mortality is very high with traditional birth attendants. They don't follow any evidence-based recent protocols, and people usually accept that Allah ki marzi se ho gaya, but people prefer not having services of skilled birth attendants, unfortunately. In current era of universal health coverage, we are challenged with poorly developed infrastructure of healthcare system, non-availability of experts, inadequately trained personnel at remote rural areas or even in suburbs. Main cities ke kareeb bhi dekh lein, the availability of people, staff is usually very less. Moreover, lack of essential supplies, drugs, equipment, electricity. If you don't have electricity for 18 hours, how the healthcare system can function? This makes things working quite impossible there. Therefore, there is an urgent need to access quality healthcare for all. PDHS 2018, it showed that 7 in 10 women reported at least one problem in accessing healthcare services. So 70% women, they reported that they had problem in access of healthcare services according to PDHS 2018. Environmental factors also contribute to our problems, lack of transportation and extreme weathers. These are the facts, especially in North, AJK, Gilgit-Baltistan and deserts of Sindh. This makes timely access of healthcare services difficult and endangering women's life further. Usually the people living in remote areas where there are no roads even, they bring the women on the charpai and then they start walking through the mountains, and then by the time they reach to the main hospital or district level, the women is usually collapsed. So overall, language barrier, lack of education for women, large family size due to traditional preference for boys. Women keeps on reproducing until they achieve optimal size of the boys, number of boys for their family. They keep on getting pregnant irrespective of their own health. Pakistani women are more vulnerable to domestic abuse, not only from the intimate partner or husband, but also from all in-laws. Everybody feels their right to abuse that young woman who is there at their disposal. There are certain traditional food taboos as well. And in my experience, I think every good quality food, like nuts are garam, anda is garam. So every good quality food is forbidden for that poor girl who is pregnant and who is getting repeatedly pregnant without any sufficient interval in between. So overall, there are unequal opportunities in nutrition, health, and education for women in Pakistan. So finally, we have a never-ending problem list. Inadequate infrastructure is one of them. Added with health services, healthcare workers, non-availability and unskilled. The attitude of healthcare workers is also very much questionable, because we never care how those poor patients they feel, what are their requirements. Empathy is lacking in our population, and so as the other services like labs, equipment, medicine, all these things are lacking, are not available for that poor women. Once these you address these issues, then there comes a non-compliance of the family. They don't bother to come to the hospitals. Even if they come to the hospital, they think wasting whole day, because the women cannot come to the hospital alone. The bread and earning person has to accompany her. They have to leave their job, or daily wages people, they have to leave their labor, and then they have to accompany that women. So they prefer not going to the hospitals, only for routine antenatal checkup, until unless there is a drastic severe emergency. Only in that situation they come to the hospital. And there is tendency to refuse expert opinion by the patient and her family. So lack of services, compliance by the patient, lack of documentation. If somebody has visited healthcare facility, there is no record of the previous visit, and then you can start the next visit from the scratch. Lack of documentation, and last but not the least, if there is no pregnancy, there will be no maternal death. So we have to address unmet need for contraception aggressively. All stakeholders should be on board. Public awareness campaigns on social media, religious scholars, all have to be on the same page in order to save maternal life and in order to improve the condition of maternal mortality in Pakistan. So what is the solution? Capacity building of people involved in pregnancy, delivery, and abortion care, the people who actually are encountering these women. These are the people who are working in underprivileged setting and who are not very well qualified. So the capacity building is very important by holding small group workshops, training courses, and if you approach them and you request them to come for the workshops, then the only thing they demand is certificate to milega. So you ensure some certification CME points for those activities as well. And then effective communication with these people. A simple one workshop will not help in improving the condition. Once you have these people who have been trained, then you are the mentors. Then you have to build effective communication with those people who have been trained by you. And I will share, I have made a WhatsApp group with 30-40 people who are involved in delivery in low resource setting. And on this WhatsApp group was made with the intention, repeatedly I've told them, whenever you are in trouble, whenever you have a problem in decision making, just give me a WhatsApp message, I will respond immediately. So what is there? I think it's more than 2 years. I am continuing with this WhatsApp group. I only receive good morning messages, Jumma Mubarak, and all these things. We are never trained for utilizing these things effectively. And sometimes once you have trained people from low resource setting, it's a good idea to visit those centers yourself as well in order to ensure the things are going well. And yeah, you can have free medical camps in their setting, and you can always help them provide help in physically in form of medicines, or pharma reps can give you a lot of are of big help regarding provision of medicines and arranging these things. These are the few activities we keep on. We have a group, small group activities. We try to have capacity building. We try to go to the basic health units far from with my students, with my team. And this is not a difficult thing. You can continue if you have, when there is a will, there is a way. And we ensure, I'm thankful to Shafat Amiri Millat University, we ensure to have these CME certificates for all of them. And this is the basic attraction when these people, they come and they attend our courses and workshops. So what are the WHO recommendation for training, or they felt the need for aggressively implementing the good quality healthcare system? What it means? That is that once you train them, these girls should be able to guide the pregnancy care throughout the maternity cycle and the newborn, because these are the one who are actually with the women throughout. They can visit the skilled birth attendants or lady health workers. They can visit their homes, or if you are working at a periphery, you have running a small clinic, the people can come to you and you can guide them, and you can train them how to take care of themselves during the maternity cycle and how to take care of the newborn. Then these healthcare workers should be able to educate women in self-care of pregnancy and how to take care after birth. Postpartum period is a very risky period when you have you are more susceptible to getting infections and other things. So you should educate these women how to have their self-care during this period. You have to train women and their families in identifying early warning signs, the complications, and timely visiting to the hospital. And these lady health workers also should know when to refer the patient to big hospital. When is the time that you need a secondary care setting or a tertiary care setting, by identifying the early warning signs. These girls should be able to monitor physical, social, and emotional well-being of the pregnant women, taking appropriate action whenever needed within the resources available, providing guidance to the community in terms of healthy living, because these are there in their community. These people belong to them and they are well aware of their cultural norms, their social norms, and people usually trust them. Avoidance of harmful practices during labor, childbirth, and immediate postpartum period. We need to train them because the traditional birth attendants, there were a lot of harmful practices which once we receive in the hospitals, a lot of harm has to be done, has already been done to these women. So we have to tell them what are the harmful practices which should never be practiced with these women. So finally, the provision of safe contraception under aseptic techniques, family planning services should be freely accessible. Unfortunately, in last 3-4 years, the subsidy on medicines were left up, and so the things which we were having from subdermal implants were available 5 years back in 200 rupees. Patient used to pay 200 rupees and they used to get contraception for 3 years. These were not free. But unfortunately, when the drug subsidy was left up, then we used to get these things in black. I myself uh, got this from Karachi, 2000 each, in 2000 rupees each subdermal implant. How the poor patients can afford this, and this is basically our responsibility, provision of safe contraception, and we should be giving them under aseptic conditions, and proper technique should be learned. Improving counseling skills. There is a need of creating awareness in the community, educating why family planning, birth spacing is important. We are not talking anything against Islam. We are not against Islam. Alhamdulillah, we are Muslim. But we need to save life of this woman who has no sufficient interval in between pregnancies to take care of her health, to take care of herself. It's just to save life of that woman that you are advocating birth spacing. Once she's in good health, once the family is ready, it's not unwanted, they can go for pregnancy. And counseling is important. You need not have to educate the patient. It's her husband, it's her all the family. Until unless the all family doesn't agree with the specific method of contraception, you cannot go with it. We need to have increasing workforce for effective contraception because it's not a simple task educating people, convincing them to have some family planning, and it takes time and time again. Throughout 9 months, we keep on telling them that once the pregnancy will end up, we are going to offer you contraception, and still once they are in labor room, they totally refuse. We will see later on, just deliver us and send us home. We need to emphasize timely referrals with adequate documentation. We have noticed poor documentation, and there should be a verbal as well as written communication. People, if somebody wants to refer the patient to me, they should call me first, asking them if I can accept that patient and whether that patient is in that condition that can be transferred or moved from that facility. So proper written and verbal communication between both parties. There should be round the clock transport services as well, because transports is something that is usually not available in late night. So the people usually wait for early morning, and till early morning everything is changed. There should be updated list of known network facilities as well, and they should know whom to contact, where to contact, and how to contact at this time. This is the most important thing, introducing research culture. This can help us gain more insight and find workable solutions, reducing maternal mortality. If we learn to apply, write up the research grant proposal, we can get more funding. International agencies are already there looking for good proposal, good working. If you give them some good idea and good research grant proposal is there, you can have good funding, and you can help these women by having your own things done in your way. Number 2, the setting outcome quality indicators. You have to set up every year. You set up the quality indicator in our department, like in Obs Gynae. I can set that whether the particular anomaly scan has been done for all patients or not. Till the end, 1 year, end of 1 year, we analyze this data, what were the problems, how many people they got this anomaly scan done or not. You analyze this data, and then you use this information for further improvement of quality of your patients. So it's very important to set quality indicators in every department. Every department will have different quality indicators, and use that data end of the year to come up with some good suggestions for improvement. So concluding, we need to work for sustainable solutions for access of healthcare facilities, provision of services, and safe practices for everyone. One for all and all for one. This is the main idea, that if we want to change the picture of maternal mortality in Pakistan, we all have to join hands together. And I would like to end my presentation on शिकवा जुल्म देशब से तो कहीं बेहतर था, अपने हिस्से की कोई शम्मा जलाते जाते. So this is our collective responsibility to work together and to change the picture for young mothers in Pakistan. Thank you so much.